where we left off yesterday, right? You're all experts now on optic neuropathy, and I remember I promised you, we started with a case yesterday, remember? And I had you write down what you thought was the answer, and you don't have to tell me, but now let's go back to that case. So this was that 39-year-old man with vision loss in his right eye to 2200 over 5 days, with a past history of hypertension, no family history of vision loss, and no improvement over the prior 5 weeks. And there is a visual field and his optic nerve appearance. So that was 5 weeks ago. And remember, I'll tell you, he had a normal macula. We're not going to do that to you, right? It's not central serous. And he had a right relative affluent pupillary defect, so we know it was a right optic neuropathy, but there were all these choices of all these categories. And so now you're experts, you were before. We know it's not elevated intraocular pressure or intracranial pressure, it's not a toxic nutritional. But I think there are 4 categories that you can at least think about in this man that you might have thought about yesterday. And there they are. You know, he's fairly young. Could this be optic neuritis? Could this be non-arteritic AION? Could it be a compressive lesion? Or could it be Leber's hereditary optic neuropathy? Okay? And just to remind you what things are particularly helpful in that diagnosis is, you know, in general, optic neuritis and Leber's are in younger patients, and in general, optic neuritis is more female and Leber's more male. One of the absolute key things is this. You really are at your peril to make the diagnosis of optic neuritis without some discomfort. It's an itis. It's painful. And then if you still don't know, you can get the MRI, but make sure it's the MRI of the orbits with fat suppression and gadolinium. And then if you still don't know, you can wait, and optic neuritis should always get better. So in this man, think about where we are with him. And if it's not enough for a few of you, I'll tell you that he has a normal MRI of his orbits. And he had no vision recovery in that right eye when you saw him at 5 weeks. And indeed, he had no vision recovery in that right eye and no involvement of the left eye for more than 1 year. So I think I'm making it a little easier for you. But some of you got it right from the get-go, and some of you got it after yesterday's lectures, and maybe some of you got it when you saw this, but I'm sure everybody got it, right? So he had a non-arteritic anterior ischemic optic neuropathy. So pat yourselves on the back. And now, here we go with things that are not so straightforward. Yes, sir?
I think in this case, a very important point is the optic disc and the contralateral eye.
Yes.
Which is a disc at rest.
Correct.
It really confirms the diagnosis.
Right. It allows you to make the diagnosis, but be careful. There are millions of people who have a small crowded nerve who are also allowed to have optic neuritis and allowed to have compressive lesions. But you are at your peril of making the diagnosis of non-arteritic anterior ischemic optic neuropathy unless you see the disc at risk on the other side. So this allowed it to be in the differential, and it turned out to be the actual result. Great. Okay. So are we ready? I think we'll fit one in before the big coffee break when you all have to check out. And then don't worry, we'll fit it all in. I'm going to cut into their time. Okay, so this is a 41-year-old woman with bilateral vision loss. She was well until 1 year earlier. Okay, so we're talking maybe even before some of you were born, but that's okay. So in June of 1992, she had some numbness and tingling of her extremities and some paresthesias in her perineal region. She had an MRI at the time and visual evoked responses which were normal. 3 months later, she noticed an obscuration of vision in her right eye. She sees an eye care professional who notes 20/20 vision in both eyes and tells her that it's a floater in her right eye. However, By December, she's 2200 in that right eye. 20/20 in the left. She has a right relative afferent pupillary defect. She has another MRI and a lumbar puncture. They're normal. She's treated with IV steroids for presumed optic neuritis and multiple sclerosis. In April of '93, she notes a blind spot in the vision in her left eye. She's now count fingers in the right eye. She's 20/30 in the left eye. She still has a right relative afferent pupillary defect with right optic disc pallor. And again, she's treated with IV steroids with no effect. And these are the fundoscopic appearance at that time with pallor of the right optic nerve and a normal appearing left optic nerve. And here is the visual field of her right optic nerve at that time. And here's the visual field of her left optic nerve. And the key here is don't just look at the place where everyone says, put your coffee cup. You need to look over here at the pattern deviation. And so she's got a little something happening centrally in the left eye, and she was noticing it. And by the time she sees you in June of 1993, about a year after she has started to have any symptoms at all, about 9 months after the first eye, the right eye, was definitely involved by something. She's now count fingers right eye, 2300 left eye. She has a right relative afferent pupillary defect, and now she has bilateral disc pallor. And here are her fields. So she has central scotoma in the right eye and what looks like a supratemporal defect in the left eye, but we know it's got to involve fixation because she's 2300 in that eye. Now, if you just looked at this, where would you localize the lesion? Yeah, this is what so-called junctional scotoma. It would be the most posterior right optic nerve and chiasm. But the fact that the vision, central vision is involved, and let me show you. So we had, remember this was the field we saw first, then it became this, and then it became this. Some central involvement, which is what we have here. So junctional scotoma gets you scared again. Maybe we missed something compressive, right? So I will tell you her repeat MRI was completely normal. So folks, what you got? She's a woman. She's a woman, she's 41. Don't get there. Don't get there. You're right. Stick with it. She's positive for the 117. Good for you. Good for you. And this is really excellent. That's exactly what it is. And that's, you have to, even the atypical cases. So the take-home message, she was positive for the 11778. Take-home message, think about labor hereditary optic neuropathy in any patient with bilateral, painless optic neuropathies, no matter which gender and what age. Yes?
The change came in 1 year, yeah?
Yes.
So that was the reason.
That's another clue. Although, of course, optic neuritis would have been within 1 year,
yes,
too, if that were what it is. And people were swearing back and forth that she had multiple sclerosis, despite negative MRI. So, very, very good. You're going to find it easy. We're going to get to another case then before the break. You're too good. All right. This is a 47-year-old African-American man with decreased vision in both eyes. So his past medical history, it's actually, so he's HIV positive, diagnosed in March of 2004. He uses cigarettes, but not alcohol. He's on the antiretroviral cocktail for his HIV. His family history is notable for hypertension, diabetes, and glaucoma in his mother. And he's a high myope, He's never been correctable to 20/20 as far as he knows. He's been followed by an optometrist, and 3 years prior to all this, the optometrist actually told him that he had glaucomatous optic nerves. His mother was also not correctable to 20/20, and he had always passed his driver's test. But in December of 2004, just like a few months before this, so what did he say, he was 47? So in December of 2004, he actually failed his driver's test, but he had last passed it 10 years prior. So we don't have to take them every year in the States. It's usually when you renew. So we know that sometime within 10 years, between the age of 37 and 47, he went over the line of the driver's test, which in most states, and in this state we're talking about here, is 20/60 vision in at least one eye. So, you see him in March of 2005. So it's a year after his HIV diagnosis. He's been on the antiretroviral drugs for that time, and he failed his driver's test about 4 months before. And he's 20/70 minus 2 in the right eye, 2400 in the left eye. He sees the control color plate only in the right and no control in the left. He has a 0.6 log unit left relative afroventricular defect. His motility is normal, his slit lamp is normal. He's on no glaucoma medications, and his intraocular pressures are 12 in both eyes. And these are his visual fields. Is this glaucoma?
No.
Bothers me for glaucoma. And here are his discs. Now, they're pretty big cups. And there's nasalization of the vessels. And the cup in the right eye is kind of vertical cup, isn't it? Kind of thing you see in glaucoma. The rim, is it pink or pale? Hard to tell when it's that little. So, yikes. We know we've got bilateral optic neuropathies, or we wouldn't be showing this case, right? Everybody's on the page with that. This is not a retinal disease. Bilateral optic neuropathy. So let's look at the categories. I think there are a few you can toss out. We don't have trauma, we don't have elevated intracranial pressure. I think everybody's good with that, but there are a whole lot of other things there. And then the Kurs probably doesn't suggest vascular, and he sure doesn't have dis at risk, right? But we're left with a bunch of others. So could this be elevated intraocular pressure? Something to at least keep in mind, but he's got IOPs of 12, some other eye glaucoma. We think, right? Okay, what do we absolutely have to rule out? We've got a progressive bilateral optic neuropathy. What does he not have at all? Right, compressive infiltrated. So we really have to take care of that. But that's easy, we can take care of that. So his MRI is completely unremarkable. He's got a few non-specific tinsels. So we don't think we've been able to rule out compressive. So which other category? Toxic metabolic. Okay, so toxic nutritional metabolic. So we better for that, right? He's not on any of the toxic things that I told you about, right? He's not on amiodarone. But let's talk about that. So we did some workup, and he's got a low B12. Could this be B12 deficiency? It's a little asymmetric, but could it be B12 deficiency? It certainly could be a contributor. Is there another category?
Hereditary, because of his mother.
Hereditary, the mother. Glaucoma, and she never passed her driver's license either. So hereditary, which hereditary?
Liver.
Yeah, see, this doesn't sound like Labor's, does it? I mean, He's had he's had non-correctable visual acuity his whole life, and it's been getting worse, and exactly, slowly progressive, not boom, boom, and it's better than 2200 in one eye. This would be unlikely labors, but it could be autosomal dominant optic atrophy, so let's see about that. Whoa, look at that. So he has a mutation in the OPA1 gene for autosomal dominant optic atrophy. Wow. And that's probably why his mother's been called glaucoma, because they get this excavated cupping. We remember all that. So Kurs disease, dominant optic atrophy, bilateral, slowly progressive, painless. They can have excavated, pale, temporally, secocentral scotomas, really fitting, right? And it's the autosomal dominant OPA1 gene codes for a mitochondrial protein. Remember, it's a problem in the nucleus, but for a protein that's destined for the mitochondria. And as a matter of fact, the DOA gene, very important for membrane stabilization in the mitochondria, for mitochondrial fusion. So, wow, he's got a mitochondrial disorder, but what else can work via mitochondrial dysfunction that's listed up here? No, but I mean, what other contributor here works via a final common pathway of mitochondrial dysfunction? B12 deficiency. Whoa. So maybe he had this mutation and the B12 deficiency pushed him over, because they're both work through mitochondrial dysfunction. But is there anything else that could perturb mitochondrial function in this guy?
Medication.
Cigarettes, yeah. What else?
Alcohol. No.
Not maybe it's alcohol. What else? This. Antiretroviral agents, which he started just 1 year before, they cause a mitochondrial myopathy. Now, he needs to be on those, right? But you take that, they're also via mitochondria. And so this, plus the OPA1 gene, plus B12 deficiency, whoa. So, stop, you're both right, it's both a breath freshener and a floor polish. I mean, it's everything. And so, you can only do with him what you can do. You can stop the cigarettes, you can supplement his B12, but there's nothing you can do about the OPA1, although the people who treated us to such a nice dinner last night might tell you that idebenone might be helpful for him too. And I know the group in Italy is seeing about that. It's just hard to measure, isn't it? But there's no way we can stop his antiretroviral agents. Well, we're on a roll here. We can even do one more before the break. This is for all the pediatric ophthalmologists in the group. So, nope, you're wrong. And you only get one lifeline, so better hold on to it. All right. So this is a 6-year-old boy with double vision. His past medical history is notable for otitis media, like every other 6-year-old boy. And he was recently hit on the head by another child, but no injury, just like every other 6-year-old boy, right? So when you start to ask these kind of historical questions, you'll find the positive answer, right? So I'm not even telling you whether it's related or not. So 1 week before you see him, he has headaches and nausea, maybe a little low-grade fever. This worsens over a few days to the point where he's vomiting, he's complaining of blurry vision and dizziness. So they take him to an urgent care facility where because of his vomiting, they rehydrate him. The head CT without contrast is normal, and he's sent home. But 1 day later, he develops binocular horizontal diplopia, which is a dreaded complication of dehydration. So that's a bad thing, right? So he comes back, and he's admitted to the hospital. And there, on examination. He's alert and oriented. He has normal neurologic and general examinations. And he has good acuity, good color vision. But he has a abduction deficit in the left eye. And I'll show you that. So the left eye is not fully abducting, so that is his double vision. What else do you want to see on his exam? Which, of course, the ER doc did not do.
LP to remove the
Oh no, I'm talking about the examination. Yeah, so in my country, emergency room doctors don't look in the back of the eyes. It's another medical legal problem. Okay, so yeah, and that's what his fundus looks like, and it goes along with the headaches, the 6 nerve palsy, right. So raised intracranial pressure. You want to see his fields. They're okay, except for an enlarged blind spot to go along with that horrendous dyskinesia. So you're worried about raised intracranial pressure, and given his whole constellation of things, what are you worried about causing that raised intracranial pressure? You think he's got idiopathic intracranial hypertension? Okay, so what are you...
Sorry.
So that's bleed. So bleed, you know, subarachnoid hemorrhage is first of all, it doesn't happen in 6-year-olds. So the youngest aneurysm is it ever to be reported is in a 10-year-old. So they don't...
Traumatic.
Okay. So, but no, traumatic subarachnoid hemorrhage would come on like
Meningitis.
Okay, a meningitis, right. So you're worried you got a 6-year-old with otitis media, maybe some fever, with a syndrome of raised intracranial pressure. Remember, a meningeal syndrome will keep the CSF from going across the meninges, and so that's one thing to think about. So I heard an LP. So the LP will be presumably both diagnostic and therapeutic, right? So it's very, very important. And so he has a lumbar puncture. It does indeed show an elevated opening pressure, but completely normal CSF. So he's got a normal CT and he's got normal CSF. He's got IIH.
But
Right.
CT was without concept, yes?
All right. So you want an MRI? Is that what I'm hearing? Okay. Here's his MRI. Also, red is normal. You think it's normal?
No.
Who sees something?
Transfers.
Okay. So the very astute will see an empty cella, but that just goes with the raised intracranial pressure. And the very astute might see a little Chiari there. But the really, really, really astute will see that if you look over this side, that's the normal flow void, and you look over this side, and you look at this in the sagittal, what is this? Yeah, these are clots. This is venous sinus thrombosis. And this was missed on this MRI.
Otitis media.
Yeah, so the thought was recurrent otitis media causing lateral sinus thrombosis, venous sinus thrombosis, chronically over time, uncompensated. And so just to point out, again, this involved his transverse, right transverse and sagittal sinus. He had a coagulation workup which was negative. He had a repeat LP to reduce the CSF pressure, and then he was anticoagulated. Please, 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 I understand that a lot of this stuff gets sent over to an ED or wherever for you. You made the diagnosis of a raised intracranial pressure syndrome when you saw the dyskidema, and you sent them to the ED for the workup. Please make sure if they did the MRI first and saw the venous sinus thrombosis correctly, that they still LP the patient before they put him on anticoagulation. Because once they're put on anticoagulation, you can't LP them. So it is so important because the LP is diagnostic, because you can get venous sinus thrombosis because of a meningitis. And so you really want to you have to know if you've got an infection to treat. Number one. And number two, it starts the treatment. And once you start the anticoagulation, you cannot include the LP without reversing the anticoagulation. Yes?
But the clinical picture was not supporting meningitis. I mean, no fever, no next step.
Well, he had some possible low-grade fever.
Meningitis signs?
You know, in a kid, they usually
6 years,
don't.
you see that.
Yeah, it's true, but not always. And this could have been a bacterial meningitis. So all the right things were done, and so we are going to stop here for the long coffee break. All right, ready to go? All right, another case. So this is a case of a 66-year-old woman who was referred with double vision. So her past medical history is non-insulin dependent diabetes mellitus, hypertension, hypothyroidism. She's on the medications with the non-brand names, as you see there. No family history. So 9 days before you see her, she develops what she feels as sinus pressure with some scant yellow nasal discharge. So she sees her primary care doctor, who treats her with an antibiotic and a beclomethasone spray. And then 3 days later, she develops horizontal binocular diplopia. She's noted at an urgent care center to have a right abduction deficit. A CT scan of the head is performed. It shows mild sinus disease. And because of her diabetes, she's diagnosed with a microvascular sixth nerve palsy, which, because I'm presenting this case, we know that's not going to be the answer. But it was a very reasonable assessment in a diabetic, and so she was sent home. However, 2 days later, she noticed that she's having drooping of her right upper lid. She has right ptosis, and now the eye doesn't move up, down, in, or out. She has normal pupils. She has normal vision. She has no ocular or facial pain. She has no decreased sensation. She no longer has any sinus pressure. She doesn't even have a headache. They check her glucose at the same urgent care center. It's a little high at 250. Her white count is normal, and they say now, well, you now have a microvascular third and a microvascular sixth. Now, that's a little unreasonable, okay? But they send her home. And they send her home, it's a Friday or a Thursday, and they say, go see a neuro-ophthalmologist. Now, remarkably, we do get her in. It's a 3-day weekend, but we see her 4 days later, which, when you think about it, is pretty quick, but obviously not quick enough. She comes in, she's afebrile, but when you lift the lid, she now has count fingers vision in the right eye. She cannot see the control color blade. She's got complete ptosis. She has equal pupils, but she now has a right relative afferent pupillary defect. Her corneal sensation is decreased on the right. Her neurologic examination is otherwise normal except for the complete ptosis and complete ophthalmoplegia of the right eye. Up, down, in, out. Okay? And here are her visual fields with a central scotoma on the right. So, localization, take it in pieces. Okay, see that, but see that's wrong. So you got to take it in pieces. Does the optic nerve run in the cavernous sinus? No. Okay, so this can't be cavernous sinus, and that makes a huge difference in the differential diagnosis. Where first? Always, you know, there's a story about. I hate to waste all this time, but there's this wonderful story, and I know we have at least one neurologist in the audience, but I'm allowed to bash neurologists because I'm one. So here we go. There's a story about two people in a hot air balloon. Who's been in a hot air balloon? Nobody? I've been in a hot air balloon. Do you know that you cannot steer a hot air balloon? Did you know that? You can make it go up and down where you catch wind or you try to get to the next place to land, but you cannot steer it. Two people in a hot air balloon, and they get lost, and they're in the clouds part, and there's somebody walking on the road down there, and they say, hello, and he says, hello. They say, where are we? And the guy that says, you're in a balloon. And one guy turns to the other in the basket of the balloon and says, figures, of all the people we run into, we run into a neurologist. How do you know he's a neurologist? He said, well, he's perfectly accurate regarding localization and not a help at all. So, not these days. Now it's okay. So in these cases, you always have to localize. Localize. So where first, then what, then now what? Where, what, now what?
Orbital apex.
And so, orbital apex, exactly. We have the right optic nerve, and we have 3, 4, 6, and corneal sensation, V1, right? Exquisite location, exquisitely located to the right orbital apex. This is, you have no idea how important that is, because the localization to the right orbital apex changes the what's that you think about. The what's at the orbital apex, one of my favorite neuroradiologists, Pat Hudgens, used to say, things at the orbital apex are always either, the differential, it's always a thing or stuff. A thing meaning a tumor, stuff meaning inflammation. Thing or stuff. You don't think vascular, you don't think anything else, thing or stuff. Okay? So, let's look at the orbital apex. So here was we get an MRI, and orbit looks pretty good. And look at the orbital apex. Looks pretty darn symmetric on both sides. Looks pretty normal. So let's look at that CT scan that she had before. There's a little bit of sinusitis on the other side, and I mean, I bet half of you in the room have that. These are the kind of things that we see all the time. What about the orbital apex? Looks pretty good there, and there. A little bit of stuff here in the posterior ethmoid. And a little bit of stuff in the ethmoid on that side. And here in the coronal you can see a little bit of stuff. Well, I can promise you, especially it sounds like the way you guys have to deal with referring to somebody else, this was a problem. All the radiologists said, well, if I called that on every scan that I see it in, we'd be having big trouble, because hundreds and thousands of people have this when they get the scan for their headache. It's a nothing. But you knew that she had a right orbital apex problem. You're not an image worshiper, right? You know it's there. You got to get somebody to figure out what it is. Because if it's a thing or stuff, it's bad. Everything at the orbital apex is bad. There's nothing good at the orbital apex. And so you got to find out what it is. Because if it's a thing and you treat it with steroids, if it's a stuff and it's infection, you got to find out what it is. So make sure that you have the right person to trust you and your localization, because I do. And in this day and age, it wasn't ENT. You'd think it would be so easy for ENT to go through the nose and get that from me at the ethmoid. But I didn't have somebody like that. I did have my neurosurgeon. My neurosurgeon who goes through the nose all the time to get into the sphenoid sinus to do pituitary tumors. So he took me seriously. I said, she's got something, she's got a thing, or she's got stuff at the orbital apex. You get it for me, okay? And I'm going to show you the biopsy that they did. And just going through the nose. And I wondered, we have pathologists here. So think about what things and what stuff we're worried about. So give me the things that would be creepy crawly at the orbital apex but wouldn't necessarily show up as a mass. So lymphomas, squamous cell carcinomas, adenocystic carcinoma, and stuff. Mucor, aspergillus, okay? She's diabetic. So these are important. So these are the frozen sections. Do we have any pathologists in the audience? All right. So this is a very atypical cell with multiple nucleoli. Here's another one. So this was read, look here, this was read as likely a form of squamous cell carcinoma. So she was sent home. She lived about 5 hours away with the idea that her primary care doctor would look for a primary, because this was felt to be metastatic carcinoma, and that she then could have radiation or whatever was necessary at home. She's coming from a long way. So she goes home, and then the permanents come back. Who can see the permanents? What's on there? What's this and this? Fungi. Non-septate hyphae. This is mucormycosis. So there she is, 300 miles away with mucor in her head. And why did that happen? Well, it turns out that fungi can stimulate cells to look atypical. And so they didn't see this on the frozen, but they saw it on the permanent. So she didn't have cancer, she had mucor. And it's actually a success story because she was brought back, she was put on IV amphotericin, and she actually had gradual improvement of her neurologic deficits to the point where she got back to 20/70 vision. She had cataracts in both eyes, a little bit better color vision. And look, notosis, full extraocular motility. Why does she have pupil sparing? Tell me something about mucor and aspergillus. They involve blood vessels. So in a way, she did have a microvascular third. It was due to fungus. And her field, much improved. So this story to me says, you have got to know where you are. Otherwise, you're going to flail. So you figure out where you are, then you take out that list. I know we used it for the optic nerve, but you can use it for anything. Of all the pathophysiologic processes, you whittle it down and then you do your investigation. So where, what, now what? Okay. This is a quickie. 48-year-old man with difficulty reading after coronary artery bypass surgery. His past medical history is known for hypertension and hypercholesterolemia, and he had good vision as long as he put on his reading glasses. And so, here's his story. He develops chest pain from angina. He has severe systemic hypertension, so he undergoes an urgent coronary artery bypass graft surgery, and there are no immediate complications, and he's sitting in the ICU, and he puts on his glasses because he wants to read, and he finds that he's having difficulty reading. So the call goes out to both the neurology and the ophthalmology resident, who arrive at the bedside at exactly the same time. And here is their combined emergent consultation. His vitals are okay, he's mildly obese, his neurologic examination is normal. The neurologist steps back, lets the ophthalmologist go forward. Visual acuity, color vision, anterior segment, intraocular pressures, pupils, confrontation visual fields, extraocular movements are all normal. And here is his fundoscopic appearance. He has difficulty reading. Can you see anything on this picture that would explain difficulty reading? And this is very important because there's abnormalities here, and I've heard the most likely thing is it's a hypertensive retinopathy. He's got these cotton wool spots all over the place. But is there anything that would give him difficulty reading? What do we need to read?
Cortex.
We need our cortex, but we need, what part of our eye do we need to read? We need the macula and the optic nerve, right? That's really what we need to read. We need the things that process our central vision. Do you see anything wrong with his optic nerves or with his macula.
Torsion.
There's nothing wrong here. Nothing wrong. Except for, no, you're supposed to have, your maculae are supposed to be a little lower than your optic nerves.
Right.
That's pretty normal looking. Okay, so what piece of information would you like at this point that you don't have? His OCT looks completely normal, and you can't get that at the bedside. Visual fields, but I did confrontation visual fields. It's not enough. So here's the guy in the ICU, right? And they're asking for formal visual fields, so I show up in a tuxedo. No, okay? I can't do formal visual fields at the bedside. He's got to be able to come over. And so he comes over, and what does he have? Sure explains his difficulty reading, doesn't it? So how do we interpret visual fields? So I do 4 questions. Is the defect in one eye or 2? 2. If the defect is in 2 eyes, so if it were in 1 eye, I know it's just in the optic nerve or eyeball, right? But if it's in 2 eyes, it could be in both optic nerves and eyeballs or chiasm, retrochiasm, right? Okay. Second question, if it's in 2 eyes, is there respect of the vertical meridian anywhere?
Yes.
Oh, there sure is, right there and there. So that puts me that tells me I'm at the chiasm or behind, right? So my third question, if there's a defect that respects the vertical, is it to the same side of the vertical, i.e. to the left or to the right in both eyes, or is it bitemporal? Same side. So it's not bitemporal, so it's not at the chiasm. So I know that it's retrochiasmal on the side of the brain opposite the defect. So in this case, I know I have a right retrochiasmal lesion, correct? Fourth question. If it's a homonymous defect, in other words, the defect's on the same side to the left or to the right of the vertical in both eyes, is it complete homonymous or incomplete homonymous?
Incomplete.
Right. So if it were a complete homonymous, it would be no further localizing value other than it is behind the chiasm on the other side of the brain. If it's incomplete, I can look for congruity, meaning that the 2 defects in each eye look similar. Is this congruous or not? Oh, it's very congruous. That's the physiologic blind spot, right? Physiologic blind spot where the optic nerve comes out. Look at the defect, exquisitely congruous. So in this case, exquisite congruity tells you that it has to be where? Occipital. So the more congruous, the more likely it is posterior. The only glitch in that is that you can have tract lesions that are exquisitely congruous too, so be careful. But this is most likely occipital, and you can even take it a step further. Now you see respect of the horizontal. Where in the occipital lobe can you have respect of the horizontal? Well, you have that calcarine cortex break. You have a superior bank of calcarine cortex, inferior bank of calcarine cortex, and it's involving macular fibers, so you are really, really posterior, right at the occipital tip. So we are looking for an inferior bank, posterior pole, occipital tip, posterior tip of the occipital lobe. And what do you think happened? What do you think happened in this man? So now you've localized it. What do you think? Well, I don't know if it's hypoperfusion. That would be watershed infarctions. Where's our neurologist? What do you think happened here? Yeah, he flipped a cookie from his, have you ever seen a cabbage perform? They clamp the aorta, and all that calcium and cholesterol and yesterday's cheeseburger goes flying down into the circulation. And I wouldn't be surprised, I know that looked like hypertensive retinopathy, and maybe indeed it is, but I wouldn't be surprised if that's little microemboli in his ophthalmic circulation as well. And he tossed a little cookie to the right occipital lobe, and you can see most posterior tip of his occipital lobe. Okay? So I think the key take-home message in this is trouble reading. Look, if you each close one eye, you don't have any trouble reading. Trouble reading implies it's a 2-eye problem. And if you have a 2-eye problem, especially if visual acuity is normal, then you need to, and the eyes look normal, you need to think brain homonymous defect in the occipital cortex, and you must get formal visual field testing, because you will miss this on confrontation visual fields. No matter how exquisitely you test with a red tomato, I heard you guys were doing, no matter how exquisitely you test it, you're going to miss it. So be humble about your confrontation visual fields, and know when, I'm not suggesting don't do them, but be very wary. Okay, good. Another cabbage problem. Another coronary artery bypass graft problem. Okay, this is an emergency consult for a 66-year-old man with blown pupils after coronary artery bypass surgery. So his past medical history was notable for coronary artery disease, unstable angina. He's had coronary surgery before. He's had angioplasties before. He's on aspirin, diltiazem, allopurinol, and nitroglycerin. Family history is notable not only for coronary artery disease, but he had a brother who had a subarachnoid hemorrhage. So here's his story. He has his coronary artery bypass graft surgery. He's had to be put on an intra-aortic balloon pump, but he makes it out, and his post-op is fairly routine. But on post-op day 2, he complains of a severe headache, photophobia, blurred vision. They give him some Percocet, and when they come around 4 hours later for his neuro checks, his vital checks, he still has something of a headache, and the nurses note blown pupils. And so you can imagine there's this immediate emergent stat consult for both the neurology resident and the ophthalmology resident to come to his bedside. It's the Friday before a 3-day weekend, isn't it always? And here is their composite examination. His blood pressure is good, he's afebrile, he's a little somnolent, but he's easily rousable, he's fully oriented. He has bilateral ptosis. It's complete in the right eye, it's partial in the left eye. He has near vision that's pretty good. He has cataracts. His confrontation visual fields are full. He has an 8mm non-reactive right pupil and a 6mm trace-reactive left pupil. He has poor adduction, elevation, and depression in both eyes, right eye worse than left, with full abduction. His fundoscopic examination is normal, and the neurologic examination is otherwise normal with no evidence of long track signs. And here's his ocular motility, with the right pupil bigger than the left, but both not very reactive. And you can see what we just described, pour up and down, pour in, and more so in the right eye than the left. Okay, so what's the first question we ask? Because we're all at heart neurologists. Remember, the eyeball is just a piece of brain. So we all are neurologists. Every one of you is a neurologist. So you want to do what first? Say, where? You have to do where first. And I entreat you to do that, because tell me your thoughts on this. This one's not so easy. So take it step by step, because what the ophthalmology resident, neurology resident, and the team did was they went for what first? Here we are, he's just finished a cabbage. And they said he's had...
Brainstem lesion.
Yeah, they said he's had a stroke, either a hemorrhage or an infarction, because he just finished a cabbage. When instead, you should be thinking about where. So someone said a brainstem lesion. How big is your brainstem? Any idea how big your medulla and your midbrain and your pons are cross-sectionally? They're about the size of an American quarter. They're really small. when you get a brainstem lesion, what else do you have besides ocular motility disturbances if you're in the right place? You should have sensory or motor or something. But I'll give you this. So where in the brainstem do you think his lesion could be to give you the presentation you're seeing? All right, so midbrain, not pons. Pons is the horizontal part, right? Midbrain is the vertical part. So that's where our, so you think he has bilateral third nerve palsies, correct? So you want it in the midbrain, but it would have to be bilateral midbrain. In general, strokes, they go stroke right, stroke left. They rarely go stroke both. But there are little arteries called arteries of Percheron which can do that. Bleeds, they can go right in the middle, so that's possible. Why would he have a bleed? It's a little weird. Yeah, it's probably a subarachnoid hemorrhage, but what causes a subarachnoid hemorrhage? Aneurysms, right? It's a subarachnoid space. You're not going to get bilateral thirds from a subarachnoid hemorrhage. Therefore, it's the fact that his brother had an aneurysm has nothing to do with an intraparenchymal bleed, right? There should be no relationship whatsoever. You can have a little hemangioma, a little cavernoma, but something's fishy here. But that's okay. You know, you don't want to miss something. So it's Friday, 3-day weekend, whatever. But we can get everything you want, right? So. The first thing is they get sent down to radiology, CT scan, stat. Rule out midbrain hemorrhage or infarction, right? Well, there's midbrain, there's no hemorrhage. Could be early for an infarction, but it's pretty normal. If you don't trust me, here it is too, a little artifact over there and there, but it looks pretty normal. Well, hey, we can get an MRI that Friday. Hey, how about that? Rule out midbrain infarction or hemorrhage. Pristine. Pristine. DWI. Pristine. Okay. Go back to your where. Instead of thinking along what because he had a cabbage, think about where. Where else can you get bilateral third nerve palsies? Besides the midbrain, where else do the two third nerves come close enough to each other that a certain process could involve them? Without involving the other cranial nerves, like you could say subarachnoid space, but then, you know, exquisitely get the 2/3. You're close. Yeah. What's there? There. All right. So the cavernous sinus is where you could get both third nerves, right? And they're close enough. And what process in the cavernous sinus could give you sudden bilateral third nerve palsies and headache?
Thromboplexy.
Not thrombosis. Thrombosis, right. Thrombosis would give you congestion, you'd see the apoplexy. Pituitary, but I didn't have it. You didn't tell me he had a pituitary tumor. He didn't know he had a pituitary tumor. He'd been impotent for several years and no one ever asked him about that, but no one had ever scanned him. So, but you say, well, wait a minute, that should have showed up on his CT or at least on his MRI. Well, you didn't ask, and they didn't ask the neuroradiologist that. And I don't know how it works here. So here's what happened. They get the report from the radiologist, no midbrain infarction, no hemorrhage. So they start him on heparin because they're so sure this was an embolic event. And that he had a stroke, rather than thinking about it. So what happens in our hospital is usually it's a resident or a fellow who does the wet reads on the radiology, and they write in a little book what they think. And then when the next day they go over it with the attending physician, then a formal report is put into the system. It's Friday. It's a 3-day weekend. The attending won't be there till Tuesday. This guy's on heparin. And what the radiologist put in his report was, the radiology fellow, no midbrain infarction or hemorrhage, incidental pituitary macroadenoma. Well, no one asked him about a pituitary macroadenoma. They just asked him to rule out midbrain hemorrhage or infarction. And sure enough, here is his pituitary adenoma, which did not expand from pituitary apoplexy up to cause chiasmal compression. It expanded sideways to get the third nerves. And this is pituitary apoplexy. Well, what, is this just coincidental? Of course it's not coincidental. Where do you see pituitary apoplexy more frequently besides spontaneously? You see it when you're having procedures like a coronary artery bypass graft surgery, because you are making the blood pressure go up and down and up and down, and you're also anticoagulating these people for the surgery. And so it's an absolute classic situation for pituitary apoplexy. But if you don't think about it, you're going to miss it. And so here's his pituitary tumor nicely here in the sella going sideways, but not up to get the chiasm. So here we have this man, 3-day weekend, being put on IV heparin. You can imagine what that's doing for his apoplexy. So luckily, we went down, saw the wet read, thought about it some more, figured it out, and so the heparin was stopped. He had the tumor removed through his ethmoid, and here he is 3 months later with complete motility. So just to remember, when you have multiple cranial nerve palsies, multiple, especially oculomotor cranial nerve palsies, do think where first. And the wheres are the cavernous sinus, and the two that you have to think about that can fool you would be pituitary apoplexy and often a posterior draining carotid cavernous fistula. And anterior draining, you usually see the big superior ophthalmic vein, you'll see a red eye. But you can have posterior draining, which just gets the cranial nerves in the cavernous sinus. A subarachnoid space process, and like a meningeal process. Neural skin cancer spread. That's a tough one because the MRI, unless you know where to look, will often appear normal. Think about Miller-Fisher syndrome, and if the pupil is not involved, myasthenia gravis can make anything. So this is just an important sort of localization, and then so where and what for multiple ocular motor nerves. Good.
Excuse me.
Yes.
I mean, in this case, why it would be like an isolated double third nerve palsy?
And not 6 and not 4, because it happens. It's probably because the pituitary is right lined up with where the third is in the dura. But the most common cranial nerve involved with pituitary apoplexy is indeed 3. All right. Oh, this one's a winner. 48-year-old woman with ophthalmoplegia and vision loss. Past medical history is unremarkable. She uses no tobacco, no alcohol. Her family history is notable for stroke and diabetes. So these are real cases. This one's going to blow your mind. Okay. So in September 2004, she is seen, oops, I'm stuck. Okay. She is seen because of bilateral ptosis, and her right eye is deviated out. I'm all twisted. They'll teach me. Turning around too many times. Whee! Okay. She's seen by her eye care specialist, bilateral ptosis, right eye deviate out, and painful vision loss. She sees a neurologist who says that she has bilateral third nerve palsies. She has a normal brain MRI. She's seen by an ophthalmologist who notes 2400 vision in the right eye 20/40 in the left eye, and she sends the patient to our comprehensive ophthalmology service, and you'll see why in a minute. And the patient tells the comprehensive doctor that my vision is worse in the right eye and I have bilateral third nerve palsies, because she remembers that that's what the neurologist told her. And so I can get rid of the vision for you right there, because what she's got is a perforated corneal ulcer. And that clearly accounts for her vision loss in the right eye. And so comprehensive gets ready to do a corneal transplant, get her a cornea, take care of this, but they've got this diagnosis of bilateral third nerve palsies, so they send her to us. And so she's count fingers in the right eye, but she has no relative afferent pupillary defect. This is really, truly explained by the corneal ulcer. I'm not trying to fool you here. But on her lid exam, she has 3 millimeters of ptosis on the right. She's got 2 millimeters of ptosis on the left. But she's got this corneal exposure and lower lid retraction. I can't see the fundus on the right. It's normal on the left. And her motility does not move in any direction fully. So I hope the video will work. I'm holding my breath. It should come. And there she is. Okay, here she is trying to open the eyes. She can't close the eyes. She can't raise it. She can raise her eyebrows, okay. There's the perforated cornea. She can't look up. She can barely look to that side, barely look to that side. What's all that about? All right. So we have, let's everybody, we have a form of ophthalmoplegia. She looked proptotic. Would you agree with that? She had that corneal exposure. She had poor eye closure. And she had ptosis bilaterally.
Endocrine.
Pardon?
Thyroid related.
Thyroid eye disease.
Yes.
Well, that's interesting. Since when does thyroid eye disease it could give you exposure? You agree with that? I agree with that. It could make the eyes ophthalmoplegic. I agree with that. It could give proptosis. I agree with that. But do you have poor eye closure for thyroid eye disease? Do you have ptosis with thyroid eye disease?
Not ptosis, but poor eye closure maybe.
So that doesn't fit. What would fit?
Sinus thrombosis.
No, that wouldn't give you poor eyelid closure. So cavernous sinus thrombosis.
Not cavernous. Cerebral sinus thrombosis.
No, that would give you raised intracranial pressure, would not affect how your eyes move or give you a problem with the facial. Think about, yeah?
No, I would look like localizes in some midbrain.
Now the midbrain. How does the midbrain give you a problem with eyelid closure? That would be which nerve?
Third.
No, eyelid closure.
Yes.
Seventh. Yeah, that's not in the midbrain, is it? That's over in the pons. It's neurologically intact. But think localization. So you localize, you came up with a what, but you were localizing to the extraocular muscles, which is a reasonable localization, especially with the proptosis. Where else can you localize? Think about it. Where else can you localize this problem? I finally had to stump you guys at some point, but I bet I haven't stumped everybody. What causes ptosis and poor orbicularis oculi closure? What disorder? What location?
You mean
If that were just by itself.
ocular myasthenia?
Ocular myasthenia. But does ocular myasthenia give you corneal exposure, proptosis? It can give you ophthalmoplegia. So we have ophthalmoplegia, poor eye closure, and ptosis could be myasthenia. And ophthalmoplegia, proptosis, and corneal exposure could be thyroid eye disease.
Autoimmune disease.
How about both? How about both? Well, why not? They're both autoimmune diseases, and they occur together way more often than you would imagine just by coincidence. Why? Because they're both autoimmune diseases. And in your career, you will see at least one patient with both thyroid eye disease and myasthenia gravis. It is not that uncommon. And so, indeed, she had positive acetylcholine receptor antibodies, she had no thymoma, she had a low TSH. Look at the big muscles to go with thyroid eye disease, and the positive acetylcholine receptor antibodies to go with myasthenia. Even if they hadn't been positive, how often are they positive in ocular myasthenia? So less than 50% in just strictly ocular myasthenia. So having positive ones are really helpful. Having negative doesn't really help you. So she had both Graves' disease, thyroid eye disease and myasthenia gravis. And so she underwent a corneal transplant in the right eye with a tarsorrhaphy to close the eye. She was treated for both myasthenia and for thyroid with PO steroids. We're good? That's a good one. That's a good one. Okay. All right. 16-year-old right-handed African-American boy with difficulty playing basketball. Past medical history and family history are unremarkable. And basically for 3 months, he had trouble playing basketball, and you'll see what his problem is. So you can look down, okay. Looks to the right, okay. And to the left, okay. And now I'm going to ask him to look up. Every time he went to look up to shoot a basketball, that happened. So he has limited up gaze, and look what happens to his eyes when he tries to look up. What's happening? Look at that. It's actually not a true nystagmus, although the end of its name has the word nystagmus on it. It shouldn't. What's happening? And look at his pupils. Non-reactive. Non-reactive to light. And when we ask him to look at near, let's see what happens. So non-reactive to light. Non-reactive to light. And to near, they both react. Come down very small. So he has, what's that called, do people think? It's called light near dissociation. No, he doesn't have an INO. He can add the duct to find. You want to see it again? Let's see if I can make it happen again.
What was the history?
So for 3 months, he's just had trouble looking. I don't want to ruin this. I'm going to go back. So for 3 months, he's just had difficulty playing basketball. You can see why he has difficulty playing basketball, because he can't look up. And when he does look up, he has a problem. And what's that problem called? So you'll see it again. Okay, here it goes. Boing, 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 boing. And from the side, look at it in a second. Here it goes.
Both sides.
Yeah, both sides. Boing, boing. The eyes are converging and they are retracting. This is called convergence retraction nystagmus. It's not really nystagmus. What it is on attempted up gaze, the eyes go in and back. And where does that localize to?
Dorsal midbrain.
Dorsal midbrain. So he has light near dissociation, he has convergence retraction nystagmus, which is not really nystagmus, it's co-contraction of the medial recti, just pulling it in. If you think about it, the way I like to think about it, it's teleologic, but basically, if you're trying to look up, you want the third nerves to work, right? But you can't look up because you have a problem with your rostral interstitial nucleus of the medial longitudinal fasciculus, or RIMLF. And so I call all the muscles that three's trying to make you look up. And so it pulls you in instead. And so it's retracting the eyeballs in because the muscle's pulling in. So he has a dorsal midbrain syndrome with an upgaze deficit, convergence retraction nystagmus, and he's got light near dissociation of his pupil. So he's a dorsal midbrain syndrome. So again, when you know the where, you have a very limited differential regarding what. When you know it's dorsal midbrain syndrome, what are the whats? It's pretty much one category.
Tumor.
Yeah, tumor. It's a thing. Not stuff. It's a thing. Rarely hydrocephalus itself can do it because the third ventricle balloons and presses down on the dorsal midbrain. But in general, if you're in the dorsal midbrain, you've got a thing. And usually the things are pineal tumors of some sort. So indeed, he's got this big tumor in his pineal region. See it here and it turned out to be a tectal plate germinoma treated with radiation therapy and chemotherapy. He also had a shunt for his hydrocephalus.
Is this the same as paranoid syndrome?
Yes. All right. 68-year-old right-handed white man with blurred vision and vertical oscillopsia. Oscillopsia is that sensation that the world is moving. Hypertension, hypocholesterolemia, tobacco use, previous very heavy alcohol use. There are his current medications. His family history is unremarkable. For the past 2 years, he's had poorly defined visual difficulties. That he now knows is that the world is moving up and down. It's worse in down gaze to the point where he cannot read. He's also less sure-footed when he walks and maybe some memory problems. And on his exam, if you put his chin down, he's 20/30. If you put his chin up, he's 20/80 because of the oscillopsia. His pupils are normal and his eye movements are full except for vertical eye movements, which we'll show you. And he has a cerebellar ataxia. And here are his eye movements. Very subtle in primary, but it's there. You see it? So what's that?
Is it missing word? I'm not understanding.
Right, what kind? You name it after the fast phase. Downbeat, right, that's downbeat. So what you can see is it's better in up gaze, it's worse in down gaze and in lateral gaze. That's very classic for downbeat nystagmus. Causes of downbeat nystagmus. Okay, good. So first you localize. Where can you get downbeat nystagmus? And the answer is at the cervical-medullary junction or in the cerebellum. And then you can think of all the things that can affect you, either structurally, like at the cervical-medullary junction, you could have an Arnold-Chiari malformation, you could have an infarct there, you could have a bleed there, but not much stuff there, right? And then in the cerebellum, you could have an infarct, you could have a tumor, midline cerebellum, or you could have a degeneration of the cerebellum, and there are various vitamin deficiencies that you could have with that as well, but you're looking for structural lesions. So in his case, he had no Chiari malformation, as you can see, but he basically had only an itty-bitty cerebellum. And is often the case, you never quite know. The first thing you have to make sure of is that he doesn't have a paraneoplastic syndrome with an underlying cancer, usually a lung cancer with this. And then when you don't have an answer, you check all these vitamins, and basically the answer is often idiopathic, or he's one of the forms of spinocerebellar degeneration. So in his case, he was given some thiamine. We told him to continue the alcohol because we figured that this was related to chronic alcohol use, which is usually what we typically find in these settings. And then we don't just dismiss him. You can make these patients better by getting them out of the problem direction. So in his case, it's worse when he looks down. So he couldn't read because his bifocals, he had to look down. So instead you give him full field readers and have him prop the material up on a cookbook stand or a music stand, and then he can read straight ahead instead of having to look down. And in a way, that's the best we could do for him. Okay. And then of course there are potentially, you could also give him glasses with prisms to force his eyes up. There are some pharmacologic options, in particular for downbeat, the aminopyridines, but that's when I agree with you, send to a neurologist. All right, this is one of my favorites. Only two left. 56-year-old man. Oh no, this is easy. You'll get this. 56-year-old man with bilateral ptosis, no fluctuation, no diplopia, normal vision. Here he is. You should be able to look at him and tell me immediately what he has. No. You see? That's why you gotta look first.
Yeah.
He looks tired. Not just from his ptosis does he look tired, but his whole face looks tired, doesn't it? And look at his eyes. Not only don't they move fully, but they're very slowly moving. In myasthenia gravis, it's a twitchy disease. You know how you can sustain up gaze with the lid and it twitches? Their eye movements twitch.
Chronic progressive.
Yeah, exactly. So, and this is a chronic, he's been like this, it's slowly progressive, and he doesn't have double vision. Most myasthenics will have double vision. The reason he doesn't is because it's so symmetric, and it's been slowly going. Where do you think he does have double vision? The only place he has double vision, given what you're seeing. And look, he has orbicularis oculi weakness and his face, some facial weakness. So this is CPEO, chronic progressive external ophthalmoplegia. And where do you think he has double vision? It's the only place they usually have double vision.
When they look up.
No? No, because the eyes are very symmetric. They're symmetric like this. So where's the one place where they have to do something different, the two eyes? Near. So they're almost always have double vision with reading because of convergence insufficiency. They can't get the eyes to go in, and so that's where they get their double vision. All right. This is my favorite. Okay. 51-year-old man who had a motor vehicle accident 3 months prior. No past medical history. He was rear-ended and hit the back of his head on the seat. He had no loss of consciousness. He says he was blind in both eyes for 12 to 24 hours in the emergency room. His eyes were shaking in the emergency room, and although his vision has come back, his eyes continue to shake, and it's worse when he moves his head and his eyes, and he's sent to us to see him because of the continued shaking, and this is his video. What do you see? You're seeing the eyes moving horizontally, right? Okay, what is this? Anybody gets this, they get a prize. They never have to come to the course again. Well, opsicoronus would be in all directions. What you're thinking about possibly is ocular flutter, which is the one that's only horizontal and it's localized to the cerebellum.
It's functional.
Ha-ha! Who said it? All right. Who can do it here in this office, in this room? Anybody? This is voluntary nystagmus. Can somebody do it? So later on you'll have the workshop where you all look at your colleague who can do this. The tip-off was, look at what he's doing with his lids. And there's this kind of squinting, and it's a form of like convergence. And if you look back at I'm going to show it to you again, because I'm going to have you look closely. When I distract him and have him look off to one side, it stops. Look at him. He's concentrating so hard. But he's good, you know. A lot of people who do this can't. There, it's gone. That comes back. You see, you can get him to make it stop. Real flutter you can't. So this is voluntary nystagmus. Very good. Okay. All right. Last one. 32-year-old woman with horizontal diplopia. This is her looking to the left at the top, looking to the right, and looking up. What's she got? Functional. Who said it? Who said it? What is this? This is spasm of the near triad. She was told she had a 6 nerve palsy plus an INO and all this sort of crap. Okay? Look at the pupils. Look what happens. This is spasm of the near triad. Watch. I can give myself a 6 nerve palsy, and so can you.
Yeah.
All right? When you see that the pupils get myotic, when they look in one direction or the other, they are invoking spasm of the near triad. It is never organic. Okay? So this person has spasm of the near triad, and all the workup that she got was completely unnecessary. So I leave you with one of my favorite phrases: learn from the mistakes of others. You can't live long enough to make them all yourself. I don't know if Randy pointed out this resource to you, but it's really an amazing free website that the North American Neuro-Ophthalmology Society supports, and it has multiple collections of videos and cases and things that you can use for your learning, for your teaching, as long as you reference where it came from. It's a wonderful repository of collections of old people and not so old people. And I will leave you with this. You've had an enormous week. I know they're still going to talk at you, but I'm delighted to have been here, and tack så mycket.
Thank you so much, Nancy. We're glad you can come back after 47 years. I hope you can come back earlier than that. Yeah, for sure. And also something for midsummer. No Harry, but and I know you're an avid reader, and you like Swedish crime novels. And you like to study the Swedish way through the books. And I couldn't find a crime novel, but I could find, everybody has heard of en man som kallas Ove. A man called, yeah. I think you're gonna like it.
All right,
Okay.
thank you so much.
Thank you.